Good afternoon, Daniel.
Hello, David. Pretty good. I can recognize your voice, huh?
Yes.
Hey, everybody. Happy New Year.
Hey, Tom.
Hello.
Well, hello, Adam.
Hello,
How are you,
Adam.
Daniel? Who is that?
This is Dave.
Oh, hey Dave. How are you? Happy New Year.
Thank you. See, he forgot my voice, Daniel.
Well,
No, it wasn't it, but your voice is pretty recognizable.
but feel free to put your camera on if you don't mind.
Oh,
I
A
am
little friendlier.
put mine on in about 15 minutes.
After your hair dries.
After I put some clothes on. Don't get wide.
spare us, Adam.
Exactly. Don't ask for things you don't really want.
Well, there you go. So I have to ask while we're waiting for people to join here.
So can you see me now, Daniel?
What's that?
Can you see me now?
There
we
you
can
go.
see you, Dave.
There you are, sir. Nice to see you.
Dave, I'm ratting Daniel out. He just sent me a note saying I wish he'd turn his camera off.
Well, Adam, we wish you'd turn yours on. So there.
There you go.
In about 10 minutes.
Nice to see you
I'm
again.
out and about. It's not it would be odd.
All right. We don't want to feel dizzy, so that's okay.
There you go. Well, there's a host of people coming on here. That's great. Gonna have to get my extra wide screen to see everybody's face now. Or at least the little black boxes with their names. Cool. So
I was
Christine,
on a call or a Zoom earlier today where there were a lot of people in one conference room and a few of us doing it virtually. And the camera in the conference room didn't cover the entire room. So you'd get these voices coming out of the air. You wouldn't have any idea who was speaking necessarily. It was a little disorientating.
Exactly. It's a throwback to the remember those giant conference calls we would have before video conference was even a thing?
Yep.
How did we navigate those conversations? How did people ask questions? I don't remember that.
It was hard because people would talk over each other all the time.
Yeah, it was challenging. That's for sure.
But there was an etiquette of sorts, right? That they seemed to happen, right? We had conference calls all the time.
Yeah, I think a lot of times they would be moderated, so that there'd be does anybody have questions from such and such an organization, or, okay, let's go around group,
Yeah.
Hey, everybody.
Putting your hand up.
Hey, Michelle.
Can you hear?
It wasn't.
Yep.
Good. Just having issues with Teams earlier. I couldn't talk my microphone wasn't working on Teams. I still figured out why.
Oh, if you switched from Zoom to Teams or, Ring Central or anything, sometimes they take over your microphone and they don't let it go until you've completely like closed out. Sometimes I even have to reboot.
Yeah.
Oh, thank you. So that's the problem because I only turn my computer off once a month.
I use different computers, one for Teams and one for Zoom.
Yeah.
So you have the two cell phones or 3 cell phones, right?
Christine, did you mean that, or you don't really?
No,
do that?
I'm absolutely serious. I have my laptop plugged in, sitting next to my desktop, and I do Teams exclusively on the laptop.
Okay.
Oh, that's
It is
funny.
so challenging.
I know there's a department
Let's
somewhere
hope you
in
don't find anyone who uses GoToMeeting.
Yeah, I've done a lot of, but it doesn't cause the same problems.
Yeah, I still have one group that sends me GoToMeeting invitations. And this morning I wound up Ring Central.
Oh, yeah. That was a big foundation one. It was the foundation's all bought into that. Or then there was Blue Jeans as well.
That
Yeah,
one
the
I've
other-
never,
Oh yeah, it's been a while since I've used Blue Jeans.
Yeah.
I haven't ever used that, I don't think.
I did one this morning that I was invited to that was, is it Google Room, Google something?
Google
Yeah.
Meet. Yeah, there's Google Meet, and I think there's a Google Room.
They seem to be the most ecumenical.
So
in
that
some ways.
that when I do Google on my cell phone, it uses a ton of power and my phone gets so hot it turns off.
Yeah, that's a problem.
Burning those computational cycles. I love it. Burn up the data. Well, I think this is great. Welcome, everybody. Gosh, a lot of new people. We'll give it another minute or so. Maybe we'll get to 50 people so far. I'll start up in more formalized, but welcome to everybody. If you do have access to a camera, feel free to turn it on. We'd love to see your face.
You want to take down the screen share for a sec so people can
Yeah.
actually see each other? And
Well,
we
you
could
should be able to-
we could do the introductions that way, Daniel.
Sure, yeah. Although you should be able to see do both, but
Well,
Yeah.
you have to scroll, so.
yeah, you're right. Okay, so let's get started. I think we're recording. So all of our meetings are public and they're all recorded and we put them on our Nick site. So for new people, you can enjoy past meetings for the last couple of years and binge watch when you run out of Netflix interest area. So we've got plenty of those there. And so this is the first meeting we're having of this year, 2023. So greetings and Happy New Year to everybody. I was looking for a greeting sign, but I didn't find one for put up on my screen here. But so welcome to folks. We generally do introductions for new people on the call here. But so instead of doing that, because that would take a lot of time because there are a lot of new people, please put your info into the chat and kind of where you hail from, and we'll kind of look at that. And we'll use that during the call here as well, since there are a lot of folks to ask questions, try to keep them as interactive as possible. And we generally run till about 5:15 or 5:30. Sometimes we go into extended overtime if the conversation gets going, but feel free to jump off if you need to. And so with that, I think people just, again, put your name and your where you're from here. And what I'll do is I'll now pull up my screenshot, tell you what we're to be doing here. All right, so you can just run through this for a second. You'll notice on the intro slide, Project Unify says, let's get technical. We're actually going to hail back to our roots, and I'll tell you about that in just a second. But what we're going to talk about today is we're going to just do a couple of brief introductions, including an overview of our strategic survey, which right before the new year, a bunch, like 25 people took it. So there's some interesting stuff that's going to guide us into the year. Just a quick review of that. And Brian is going to just give a brief update on our Thompson scenario and the work we're doing with Gravity Project. Excited about that. And then our featured guests this afternoon are Ken Salyards and Michelle Zancan, Ken Lord, Lisa Moon, and talking a bit about what the Administration for Children and Families Interoperability Initiative is up to in New Jersey and in Connecticut and with CRISP, and some real interesting and exciting things that we've been tracking now for a while. And Dr. McCoy will help sort of introduce and moderate that because of her involvement with all of that. So with that, let me ask Brian to say a few words, say greetings, and then just talk a little bit about our Thompson folks.
And this is also motivation for me to get on camera here.
Yeah, that's the point.
So we at the end of November last year, we extended the user story catalog a little bit, added 3 new user stories for the coming year, at least to start with for the coming year. I'm sure that we will add more, as Dr. McCoy and I have discussed just yesterday, wasn't it? We added in 2 new personas to the group. We added in John Thompson's parents, Randall Thompson and Geraldine Thompson, and we gave Ruth, Sarah's mother, a last name, since apparently we had written about her in copious detail over the last 3 or 4 years, but never gave her the last name, Hernandez. These we, after extending the user stories, extending the set of personas, we finally got around to, or I finally got around to submitting the Unify Thompson family to the Gravity Project to add to the Gravity Project's list of personas. And I have not yet heard back from the Gravity Project about that. I just sent Demry another, kind of poke. Hey, what's going on there? But I actually expect that we will start using Ruth Hernandez as one of the personas that we test with this coming weekend at the HL7 Gravity Connect-a-thon.
Cool.
So that's my spiel about the Thompson family.
Thanks, Brian. For folks who may not be familiar with them, this work evolved over actually pre-COVID, and our initial work with the Integrated Care for Kids program, as we encountered it, wanted to really reflect the complexity of not only individuals but whole families and the interaction between them when they're multi-system involved. So it's been through a lot of iterations. There's a lot of material around that, and part of our goal is to standardize around scenarios and personas so we can learn from one another and learn from their interactions together. And I think a lot of the work we've been doing and will be doing are actually based on that idea of being able to really think about a whole family unit. So a lot of material about the Thompsons on the Nick site. And Christine, I don't know if you wanted to say anything about that at the moment in time, because you were instrumental in that when we got started with them.
With regard to the Thompson family, sorry.
Yeah.
I'm reading the chat, trying to figure out everybody who's here.
Yeah.
Well, actually, I was going to ask Brian a question, and then I can bring it back to that. So, Brian, is there a link where people can find all of the Gravity adopted personas? So that's my question for Brian. And yeah, as everyone else said, this family has been very instrumental in helping to think through a lot of the scenarios for the CMMI Integrated Care for Kids project, because it's multi-generational, which really is the focus of the Integrated Care for Kids project. And so now we'll add, more folks from a second generation. And for those of you not familiar with this specific process, in addition to having these written stories, of which there's significantly more than what you see in the graphic on the screen here, there's actually data associated with the personas that have been built out, so that structured data can be used when testing interoperability of software. So it's more than just a story to talk about why we do what we do, but actually we can use these folks and information about their various health conditions and social conditions in order to test the interoperability as well too.
Cool. Thank you much. So let me move along here and see if my screen will work here. So we did at the end of the year, we did our last meeting. We had a lot of discussion, had some discussion, particularly around some questions around what Unify these meetings could do over the next year. What would be most useful for the people who participated? Because over the last, gosh, maybe 2 years, certainly the last year and a half, and certainly over COVID, there's a group of folks who have been meeting around a lot of these topics, including the focusing on Thompsons and how to integrate that. So we want to make sure we're using the time, because it's pretty much all volunteer at this point, to guide this national conversation. So did a survey, and I just summarized the results really quickly, and I just want to go through this. So as we talk about what happens over the next couple of months and quarters, it kind of guides some of our thinking. So we have some continuity, and we can use our time most effectively to do that. So the first question was most favorable parts. People love the discussions and presentations. It's a good format. No surprise there. We were meeting almost every week for a while, and I think that with everything going on, especially virtually, kind of a twice a month cadence or so is what people indicated was sort of the median for frequency. This was an interesting question that we actually talked about quite a bit, which was how technical should these calls be? Because as I said at the very start of this thing, this webinar series actually emerged from a session that we did in San Diego at their conference, oh God, 4 or 5 years ago, maybe 4 years ago, where Carrie Huff, who was the associate director there, leading their Connect Well and Get Well, or their Connect Well efforts in particular.
Live Well.
Live Well, thank you. Live Well San Diego was very gracious and always hosting sort of people who were excited about learning about what San Diego was doing. And at one point she said, we love this, we love talking about our work, but we really love learning from other people. So it would be great if we could really sort of hear from other technical people. So we put together a session at that in-person conference, and we called it Let's Get Technical. And Mary Sarah, I think you were there, and Christine was there, and others. And it was room to room. It was the room, shoulder to shoulder in the room. It was so many people in the room. They were all really super interested in the technology. So it was a geek speak for 2 hours. And we came away from that, and it was really interesting because we said, you know what, there's a real interest in people having a forum to talk technical. So over the years, we've been more or less technical on these calls. And so the question here was, how technical should it be? And so you can see that current level, which is pretty sophisticated for a general webinar, is where people want to go, but there's a lot of interest in going more technical. And so we're going to propose as we go forward over the months to actually sort of call out sessions that are actually even more technical yet for those folks, both to participate and also to be forewarned. But it's an interesting and an exciting forum. Some of the topics of interest people indicated more work on standards, which is, today we're gonna hear a lot about that, APIs, data models, and ontologies. Yes, Eric, I think if Eric is on the phone with us, people do want to hear about ontologies, just not at the front of the list. Some of the educational topics, consent management, which is great because that's really so much of our focus on what we've been doing around consent management. And of course, then data sharing, interoperability, AI and NLP, and just general innovation, all supportive of and involved with consent management. And then kind of asking the question slightly differently, like what areas most interest to focus on in 2023. One was this area of educational programs. Let's focus on consent implementation and then technical demonstrations. And we'll hear today of a lot of the technical stuff that's going on, and other folks on this call can talk about some of the connect-a-thons coming up and how some of these materials are sort of filtering into that. And overall, people were pretty satisfied out of 5 points. So I gave all of us a good grade on that one. So with that, just a couple of words about what's coming up, and then we're gonna turn to Ken and company to talk. But so as I said, we're gonna meet every 2 weeks. So in 2 weeks, on the 25th, we're going to have a presentation and discussion led by Chris, who's on the call today. And I think Denise as well is going to be joining us as well. Denise Chrysler from the Network for Public Health Law to talk about the Office of Civil Rights notice for commentary on the new 42 parts 2, which is at the core of all the behavioral health stuff. So they've volunteered to come talk to us about that and get that conversation started, really critical part. So thank you for that. We also are planning on hearing more from May June and company around the Flutter-based firework in New Jersey and stuff. We have comments we'll hear today from folks who are involved with that, but to go a little deeper dive on that sometime in February. And then I think our colleagues and friends from Arizona will come talk about some of the youth diversion programs that are happening in Yavapai County in Arizona, which is those of you who were on earlier in the year, we heard some other presentations about youth diversion programs in Pima County, I think. Correct me if I'm wrong, Sean.
Do you think I'll ever be able to do more than just?
So other possible.
I'm not talking or anything.
Hold on.
I hope you can, sweetie. I want you to feel better.
If you, I don't see who is out loud here.
I think that was Craig Elmer.
Okay. Yeah. Okay. Anyway.
For his own safety.
Yeah, right. Thank you. Okay. Monitor your microphones. So some of the other potential technical topics as we're going to go into next year, we've been having conversations with folks and HIMSS and IHE around the consent work showcase, using consent at the interoperability showcase, and some discussions around policy workshops. Connectathons, other accelerator programs, Helios, we'd love to hear from those guys, the ontologies work, and some of our pilot sites for the consent work. And hopefully the National Science Foundation will be able to sort of follow up on those guys and whole person initiatives. A lot of that work in California in particular. So lots of topics. And we'll, I guess as we go forward, some of these will become more obvious to integrate into the work we're doing, particularly around consent, and others will be sort of opportunistic as people are available and as we can see how they can fit into the overall schedule. So we'll continue to kind of seek feedback and other ideas about what can move this body of work forward in the most sort of interesting and educational way. So stay tuned for more of that. So with that, let me turn over to Christine to introduce Ken and company and sort of set up the conversation for today and kind of what we'll hear from them. And then I can run the slides. I've got Ken's slides and I think Michelle is going to run hers. Christine, are you there?
Sorry, I muted myself after the earlier thing. So Sid had a question down at the bottom of the chat.
Okay.
He asked if we're going to be more technical or are we going to have less focus on policy?
I think we're going to try to do both. Right. So it really is a question of cadence, really, as I come back to that, is how much time do people have? But I think that what's unique is the blend of having both a technical and a policy conversation in the same group of people. And so hopefully we can kind of go back and forth between those and link those together. And ideally in implementation sites, like where people are actually doing the work, so we can actually see the impact of the policy in real time around whether or not it's early intervention or homelessness or behavioral health or whatever. But all suggestions are welcome on how to sort of navigate that with the amount of time and expertise that we need.
Great. All right. Well, with that, I just want to clarify with Ken and Michelle that we'll actually only be hearing from the two of you. Is that correct?
Yeah, Lisa was not able to make it, but I think Ken covered the SPHA information in his slide.
Okay, all right. So sorry, just we weren't sure if we were having 4 presenters or 2, but it looks like we're going to have 2. So welcome to a couple of our regulars as presenters today. So Ken Salyards from the Administration for Children and Families, and Michelle Zancan, who along with myself and a few other folks are supporting Ken in his initiative at ACF. And they will give us an overview about the work that is happening there and how that relates to work of the couple of the integrated care for kids projects, because of the commonality of the open source software that is being used in order to build out those programs as well. So I will let Ken take it away.
Cool. Thanks, Christine.
So Ken, I'm going to pull up your slides in just a second. And your bio and Michelle's bio are in the PowerPoint, so we'll distribute those and make that available. But I've known Ken for a long time from SAMHSA days, and then his migration to ACF and continuation of the great work there. So I'm really glad to invite you to present today and share a little bit of what you've been doing. And here we go. All right. Do you see?
Yep, it's up.
Okay.
So hello, everyone. I'm Ken Salyards. I'm an information technology specialist with ACF, and I'm the ACF interoperability lead. So next slide. So first, we'll talk a little bit about our interoperability contract. It's a 5-year contract. Base year started in 2022, and we just option year 1 for 2023. We created the HL7 Human and Social Services Work Group, HSS, and we support 2 of the interoperability grants that one, well, we'll talk about them in the next slide, I think. And then we support the operational data hub, known as ODH. And that ODH is brought forth from what we called OCP, Omnibus Care Plan at SAMHSA. And so ODH is on FHIR version 4, where OCP was on FHIR version 3. So OCP is used in Prince George's County, and they've been using it for quite a while for a diabetes application. Next slide. So we have 2 grants. One is CRISP, Chesapeake Regional Information System, and CRISP is the state of Maryland designated health information exchange. And so we are exchanging data from Chesapeake to the New Jersey Inc. And that's why they have one of our ACF grants. And then the next slide, the second grant went to Delaware School-Based Health Alliance, SBHA. And what we are doing with them is moving their whole Apex infrastructure to FHIR. And Ken Lord and Lisa have been working on that project. And Ken and his team have mapped their data content that they receive from EHRs and other places into FHIR. So next slide. So ACF created the HL7 Human and Social Services, HSS work group, and it's missing half the parentheses. And the first HSS project is the Human Services Data Specification Directory, based on open referral. And we've been doing that in partnership with the Administration for Community Living, ACL. And so ACL funded the HSDS directory. And what we did, well, we did a couple things. One is we facilitated interrogating the directory and bringing back data content. And we also created a FHIR facade to put in front of the directory service so that you could query it with a FHIR query and then bring data back as FHIR instruments. So that was a pretty interesting and intense process. We participated in several connect-a-thons to facilitate that. We also created a request for comment, which is currently in review at ACF as an interoperability rule, which we created with ONC. So hopefully we'll get that out in the February-March timeframe. Next
Hey, Ken,
slide.
Can I ask you just to spend a second on the first bullet point there and what your goal is? Because that was a big move to actually get HHS stood up, and I just want you to the gravity of that, one might say, is not to be missed. But if you want to say
That's
a
true.
few more words, that'd be great.
I mean, it was an interesting process, and the work was mostly done by space.
Evelyn was doing that. Wasn't EMI advisors and Evelyn?
Yeah,
Right.
EMI
Right.
and Evelyn led the process for that, and they carried it across the finish line. It was an interesting process, to say the least. So the politics in HL7 were quite interesting. So
does it mean it has a home now? Does Human Services actually, have you embedded Human Services, or have you helped embed it in HL7 land to at least
correct.
begin to carve out the needs of different?
Yeah, and I may talk about this later, but what we're doing with the HSS work group now is we're putting together a PSS to facilitate person-centered care. So if anyone's super familiar with how the process is today in FHIR, in order to get to person, you have to go through patient. So it was really, in my humble opinion, a poorly modeled process there. So, and of course, because healthcare was the first and the most, money environment, they didn't worry about anything else but patient-centered care. So at any rate, we are, as I said, working on a PSS, and we will propose how we would see person-centered care and allow a person to exist without being a patient. Today in FHIR, the only way you can exist is as a patient. And they do have a person resource, but as I said, you have to go through patient to get to it. So we will straighten out that modeling and put forth the proposal to create person-centered.
That'd be great.
Did that help?
Yeah, quite a bit, yes.
And we
But
have a couple of other questions in the chat that have popped up while you're talking, Ken.
Okay.
So, Melanie Combs-Dyer asked how the HSDS directory is different from the National Directory for Healthcare RFI that came out from CMS.
Yeah, I haven't seen the RFI yet, but I believe it's more provider directory oriented than referral. You know, it's based on referrals to providers and that sort of thing, I believe. And instead of just being able to go to any sort of Unite Us or 201.
They both represent identical. I don't know if they're purely, they're meant to be identical mappings between, I guess, HSDS, the open referral standard, and FHIR. Greg was actually doing double duty, coming to the National Directory meetings and doing those mappings too. But the National Directory is like another Project Unified meeting in its own right. So,
So are you saying the endpoints should be the same? Is that what you're saying?
absolutely, everything should be the same. If it's not the same, then one of them didn't do the mapping right.
Okay.
Well, that'll probably be the case when all is said and done. But at any rate, I won't go into that.
And then there was another question that Matt had actually asked about the interoperability rule. If you had a few tidbits you wanted to share about what might be coming there, if it's totally under wraps still at this point.
So the interoperability rule, it is based on a FHIR and USCDI and USCDI plus. So I won't say much more than that at this moment, because it could change from where it is now to when it gets released. So I suspect it won't change much, if any. But at any rate, let's see here. So I think
Want to move to objectives?
did I cover the last bullet on that previous slide?
Yes.
Yeah.
Okay. So now this slide talks about the rule. So to utilize FHIR, as I said, USCDI and USCDI plus to create FHIR data sets for human services and to continue to facilitate the use of FHIR infrastructure, smart on FHIR. And you know, the infrastructure that we use, which as I referred to earlier, is called ODH, the Operational Data Hub, which is implemented in New Jersey Inc. and is being implemented in the Connecticut Inc. Projects. And as I mentioned, Prince George's County uses the original version that we refer to as OCP. So we changed them because their focus somewhat changed from Prince George's County use and the use for Inc. and in the Inc. grants. So next slide. So what we're trying to do is, from ACF perspective, is look at enhancing data interoperability among ACF data sets, so that we can look at the different data sets, TANF and child welfare and so on and so forth, and try to begin to be able to match data across those data sets, and there are several of them, and try to make the matching of those data, of the data content in those data models to be able to utilize data across all those different organizational units within ACF. So, we want to standardize data exchange. We want to implement HL7 standards-based capabilities. And we want to integrate health information with human and social services information. And this is key to facilitate childcare, right? Because the childcare systems that ACF has implemented are based on just flat file content, and it makes it difficult to compare and identify data across those data sets. So we want to cultivate a data exchange culture versus sort of a culture of this data is mine and you can't look at it and so on and so forth. And so it's very makeshift. I mean, they just built a new TANF system based on 20th century software. So, we're not doing any favors for ourselves from an ACF perspective.
Ken,
Next
quick
slide.
question for you.
Sure.
Is your focus, and I know you're going to talk about that next couple slides, but just to tee it up, in terms of facilitating the data exchange, are you wanting to do that at the federal level, or are you in providing the supports to make that happen at the county and state levels? Because I think the feds mostly get de-identified aggregate data as opposed to the PHI at the local level. So
it depends on the data sets. Sometimes in data sets, they get data content at the individual level, and other times they get aggregated data. It depends on the system and depends on, what the government, the Congress decided to do for a particular data set. But for example, we take data from USDA and we compare it to TANF data in a system called Paris, which tries to determine whether or not people are trying to double dip in multiple states, right? So, from a fraud and abuse perspective, but that's really all it's used for. And so, the one data set belongs to the Department of Agriculture, and then the TANF data set belongs to TANF or to ACF. And so those data comparisons take place, but only the outputs of, this person may be trying to collect TANF and agriculture funds from multiple states. And so those are the kind of things that they're trying to do there. And the Paris system's pretty big and pretty complex, and you can imagine why, trying to map the different data sets from one federal organization to another.
Yeah, sure.
So, what we're really after is enhancing data interoperability. And in the end, then, the more standardized the data is, the more opportunity you have in order to look at the data, to review the data, to grasp things out of the data that help you facilitate your programs. So that's what we're trying to do. So we want to basically, that whole conversation was about modernizing legacy informations. systems, and so we have greater agility, scalability, and efficiency in operations to meet evolving mission needs by modernizing legacy IT infrastructure, processes, and systems using FHIR. And you know, like we have requirements for a case management system, but we have not ever created a model case management system based on those data standards and requirements, right? And to also share technology solutions, because then we can develop and scale reusable emerging technology solutions, tailorable on-demand shared service solutions by utilizing FHIR, for example, and smart on FHIR modular mechanisms to encourage enterprise level collaboration. So one thing about FHIR, you know, and smart on FHIR is that it is very easy to add content components to the system using smart on FHIR, because you can make a small application that just does one or two things. And then, you know, if you need to change it, it's very easy to change that kind of infrastructure versus having to dig through the whole system to try to find where it is that something is broken. And it also, you know, encourages enterprise level collaboration, which we currently don't have.
It also, just another added point for the smart on FHIR launching technology, it allows you to leverage existing investment. So if you've got technology that you've already invested in that does one component that you really like, your staff is familiar with it, that can be leveraged through smart on FHIR launching out of your FHIR-based or FHIR compliant technology.
Yeah, and the first time we used that was for the consent process, so that, you know, the consent was in its own environment. And when you know, had to change it or, you know, facilitate some change in it or whatever, you only had to go to one place to facilitate those changes and stuff. And it makes it very easy to create an infrastructure to support that. And I believe, I may be mistaken, but I believe the pieces of code that was done for the collection of information about children and stuff was also smart on FHIR launched. Is that correct, Michelle?
The assessment tool?
Yep.
The assessment tool is FHIR compliant, and it's actually that was developed by May, June. It is smart on FHIR, or it is FHIR compliant. It's not, I don't think that it's a smart on FHIR launch, but it's connected in a shared database with the rest of the solution, the rest of the technological solution. So all the data is stored and shared between the different, like the portal, and it's shared with and throughout the case management system, etc.
Right. And so that probably would have been a good opportunity to use smart on FHIR for those assessments, simply because then you could use them, you know, through other, you know, the client, if you will, or the person could actually launch the assessment, and then, you know, when they're done, the assessment would store the data in the FHIR store. But
yeah,
at any rate.
We did do that. We just did it in a little bit different way, but I'm going to demonstrate when we get to the demonstration part. I've got some Smart on Fire launches that we did that we can demonstrate as well to see
Yep.
that.
Then we'll have a detailed presentation on that assessment tool in next month. So coming soon.
Cool. Little bits and pieces.
A lot of stuff you got going on.
Indeed. So, you know, both the Inc. grants, the two Inc. grants, New Jersey and Connecticut, use FHIR version for infrastructure. They use several assessments, which we just talked about. And, you know, I thought they were Smart on Fire launched, but apparently they're not at this moment. ACF is exploring the process of moving our data infrastructure to FHIR over time for child welfare, child support, foster care, and TANF, for example, and a couple others too that are not in there. But at any rate, next slide.
Is that child support and enforcement?
I'm sorry?
Is it, when you said child support, is that child support enforcement agency? The
Yeah,
department?
there is child support enforcement. And there's other opportunities too, for, you know, children and people that are used for trafficking and things of that nature. So, you know, there are those opportunities as well.
Right.
So from the regulation perspective, we're required to issue an exchange regulation for certain programs. And the ones on the bottom are just the bigger ones. And then the other ones, as you saw on the previous screen. So as I said earlier, we're working on an RFC. We've put it together, and it is being reviewed, and then it'll go through legislative affairs in order to get published.
Ken, what's it? I'm not familiar with the acronym RFC. Is that a request for?
Request for comment.
What's a request for comment?
You could
Like an RFI?
substitute RFI for that.
Oh, okay.
You know, just just who's controlling the process and what they like to call it.
Yeah. Okay.
And so from a funding perspective, the two grants receive $600,000 each. They are 18-month-long grants, and the interoperability contract is funded for $1 million. The first year, we funded it at 1.1 million. And now the following 4 years, option years, would be 1 million each. And then the contract also provides grantee support to utilize FHIR. So the two grants basically were put together in order to move to FHIR for their infrastructure. And that's what they were for. So, you know, ACF, we work with ACL and ONC. We have meetings every other week. ACL funded the HSDS FHIR directory. And what we did was we helped them to test the directory. And we did several connect-a-thons with them to facilitate that. And so, you know, ACF works with commercial organizations as well. And, you know, we want to increase that working process so we can add more value to the standardization process. And ONC to help facilitate the ACF to use USCDI Plus to define our data infrastructure. And I think that might be it. Yep. So any burning questions?
So Ken, if I can ask just a couple of questions about the two cooperative agreements. The first one with Chris, as I understand it, is really about care plans being exchanged.
Correct.
Is that correct?
Yep.
And I don't know if you or Michelle know, are they being exchanged as fire care plans or CDAs, or do we know yet how that's happening?
They're being exchanged. They're both fire care plans. It's being exchanged as a moment in time, as opposed to like an ongoing exchange. Does that make sense? But they both are fire compliant care plans.
But
And
it really wouldn't matter whether they were CDAs or fire, because we can take a CDA document and create a fire bundle from it and store it in the fire data store. So it's not
right. But again, that just sort of being the point there is the care plan exchange across state lines occurring in that project. And then the second project with the School-Based Health Alliance, the data that the School-Based Health Alliance was already collecting was coming from a combination of EHRs and school information systems. So I think that's what's really exciting there, is that it's the first time that we've got that data coming out of the school information systems, as well as the EHR data, and both of those being transformed so that they're fire compliant as well. I think I've got that right.
And you know, it's interesting because they were using comma delimited data from the EHR, and they weren't aware that they could get a CDA document out of the EHR. So you know, we helped them with that, and then we mapped all their incoming data into FHIR and able to store it in a FHIR data store.
And you know, I think that's it's probably very common as we start to have organizations that are not medical organizations starting to work more in this arena. They haven't had, you know, this great investment of health IT dollars that medicine has had over the last decade or so. And so they're really just not on top of these capabilities. So it's really great to be bringing those capabilities into this intersection between, in this case, the education and the medical care sectors.
Yep, I agree. Any other questions?
Only other question I had was, it sounds like there's more activity at ACF with investments in technology and people, and that's a good thing, to really, you know, put some more resources at the federal level around that, because it's not always been that way within ACF, I know.
Yeah, well, at the end of January, we'll be moving from OPRI and DDI into and report to the CTO of ACF. So hopefully that'll give more visibility to the work that we're doing and the processes that we have to go through to get things done. And hopefully it'll give us more money over time.
Yeah, I can. Tom here. Quick question. You mentioned earlier in the presentation that you guys were working on something that would basically reorganize the person versus patient concept.
Correct.
What do you think? Is there a downstream impact that you see to either US CDI or US Core as a result of that? And if you do see that, what do you think is the timing on it?
Yeah, so it's very possible. However, for most systems who are using patient today, which, you know, are most implementations, if not all, you know, there'll be very little change to them because they're already going through patient and using patient. And, you know, we're not going to change the patient connections and things of that nature, but we are going to separate person from patient such that you can actually utilize a person, and we're working through what kind of other things could also hang off of person as well as patient, observations and conditions and things of that nature. So, we have to remember that everyone is a person, but they actually only take on the role of patient when they have an illness or they go see the doctor or whatever. So if you go into a doctor's office for a checkup, you're a patient for half hour, an hour or so. And then when you leave, you're a person. People on the street don't refer to you as a patient, right? Because that's really your private business, not, everybody and don't know, right? So I think that once we get those resources realigned so that you can use them without patient being in the middle, I think it'll make FHIR much more usable across all types of systems. So that's our perspective, certainly willing to hear others.
Some of the feedback that we've gotten so far about that is coming from social services and community-based organizations. They want to integrate, they want to be part of the discussion, and they want to be part of this holistic view of a person. But the FHIR standard based as it is now under patient makes it extremely healthcare specific. And so by changing that focus, it's going to embrace, it's kind of a touchy-feely word, but embrace the social services communities and providers in a way that it's not just they're the redheaded stepchild. We actually want them to be part of this discussion, and we need them to be part of this discussion, and we need them to feel like they're part of this discussion. And if we keep using patient, then that's contrary to what they use in mental and behavioral health. That's contrary to what they use in social services.
Right.
And on a much sort of lighter front, anyone who's a caregiver for someone else, right now to be set up in those portals in order to be the parent or be the, another adult caring for an older adult or a disabled person, you also have to get set up as a patient. So it's just a strange situation that would be resolved by fixing this problem.
Correct.
Well,
The only other thing I would add, this is Dr. Washington from SAMHSA. Hi, Ken.
Hey, Wilson, how you doing?
It's, two things. One, I like the movement toward the person because, as Ken mentioned, and I'll phrase it a little different, every patient is a person, but not every person is a patient. But there's an ecosystem out there that requires, even on the clinical side, a look upstream to find out, because a lot of issues upstream may be social services connected and not so much patient connected. And clinicians need to know that, because, for example, something as simple as medication compliance. For a patient, you may not know the child is non-compliant because they're living on the bridge with a family.
Right.
And their medications are being stolen because they're part of the social services system. But that's driving their compliance issue. And so the doctor needs to know that this person is homeless, and that could impact compliance. And that's just a tip of the iceberg. It gets really complicated. So I like the movement toward connect, and I call it the ecosystem, in a way that we capture everyone and we capture all the pre-events that may lead to a clinical event.
Right. And to what was it, Mary Sarah Jones, are we just referring to the recipient of services? And the answer to that is it depends on what we encompass as services, right? and then the caregiver, the parent. Yes, all these folks are persons, right? And they take on roles to facilitate care for another person or patient or whatever. So the, you know, I mean, in the behavioral health community, you know, you have different acronyms for a person. They're a client, they're a consumer, they're a something, they're, you know, and I mean, if you call a person that's getting behavioral health services, calling them a consumer, to me, is an affront to that person, right? And you know, just tag and, you know, placing a tag on them to say, oh, you know, this person is a consumer of drugs, and so, you know, we have to you know, do something with them or whatever. So the terminology gets confusing after a while, especially when, you know, systems are built. One will say the person is a client, another one will say they're a consumer, another one will say they're something else and something else and something else, and you know what I mean, they're all persons, right? If they're under healthcare coverage, then they become a patient for some period of time, right?
And you know, Sid put another comment in there about, you know, families as well. And I think, you know, that's the other thing we're trying to enable, is that we want to be able to look at things that are interventions for families, for households, for other units as well. You know, even just wearing my doctor hat, going back to medical care and diabetes, you know, the people who need diabetes education are the people who go to the grocery store and the people who do the cooking. Those are probably not my patients. So, but you know, they actually need to be recipients of part of that global intervention as well too. So it's the household then that ends up benefiting.
Right.
So are we keeping those structures? I guess that's where my question was going, is there's lots of persons. So going from patient to person doesn't solve a problem. I think it creates a problem because there's so many persons, and maintaining that family relationship so that you can have family focused treatment, so that you know who the custodial individual is to get consent from. There's a lot of reasons, or the caregivers, those relationships, which are not always familial in some groups, right? They become really kind of unique, but being able to understand those relationships and how they engage with each other, and who's receiving the service or the care, whether it's healthcare or human service care, and how the others relate to them. I think that's the core issue.
Yep. And I can't agree with you more. It's in FHIR today, patient has I would call them synonyms, right? And they would expect you to place a synonym on a particular patient for something like a relationship and so on and so forth. So but that's, you know, again, you have to become a patient in order to have some type of relationship with somebody else, and that's not necessarily always the case, right? If you just need a food source, you typically won't go to a healthcare place to find, you know, where the food source that you need is, right? And you don't need to be a patient to go to a food bank, right?
Right. Well, it sounds to me that this is a potential topic of greater conversation as we look at describing, especially in the Inc. world, right? In any kind of family environment or household environment, it's going to become more and more important. So I think that I think we're.
I
gonna-
agree. I mean, it's not, you know, a slam dunk for sure.
And so Ken, is the best place for people to engage in this, the HSS working group, like where, you know, I know that that is a hotbed of this. Is there any place else they should be if they really want to dig in and solve the problems, not create more problems, as Mary Sarah said?
Sure. I mean, that would be a great place to gather. This environment here would be a good place to get groups of people who would like to work on these kinds of problems. Yeah.
Sounds like a good topic for a work group.
Yep.
Yeah.
Exactly.
Yeah, including, you know, Paul's comment, he just popped up in the chat too.
Yep.
But I think we should probably move on to Michelle's demonstration of the operational data hub that Ken's been describing for all of us. So we can get a sense of what its current capacities are. And I think Michelle's going to also talk about some things that are coming soon and then maybe coming a little bit farther out in the future in terms of the capacity of the system at this point in time.
Yeah.
So Michelle, are you ready?
I'm ready. Hopefully I don't time out. Have had anything up for a while. Okay. So I'm going to run through pretty much I want to highlight. So I've done this full demonstration of the operational data hub in the past. And if anybody would want a full demonstration, certainly reach out. We can set up a time for that. But the purpose today was to kind of go over some of the newer things that ACF has been focused, or that we've been focused on developing in the operational data hub under the guidance of ACF over the past year, and work that we're currently working on, and then work that we're looking to continue working on throughout 2023. One of the big things that we did focus on, Ken had mentioned the work done under the HL7 HSS work group for HSDS community resource guides. Under the Inc. in New Jersey, we use New Jersey Inc. is using this as their care management platform. We have teamed up with Open City Labs to do a smart launch of a tool that enables referral to be made to the community-based resources in New Jersey. They use 211, which is linked to their 211 national. And they're using that they will be using that HSDS model as it goes through the process of being approved and then implemented. This system, so I started here in the ODH. I was in this client's record, Jonathan Harris. I did a quick smart launch here straight from that person's record and went into Open City Labs. So this is kind of a between tool that allows for the FHIR transfer of data. It signs me in directly to an account for this individual with this individual's date and this individual's address. So then that way the community resources that are listed for me are listed near the address that's listed in here so that it's relevant. So if I wanted to do a referral to a community-based service that's provided, say housing, you would select that in your search over here. Different options come up. They're all based on location. So then I might choose this one to add, and then I want to refer. So I'll do the referral here. I'm going to say we're looking at mortgage payment or rent payment assistance. We said it was a housing need. I'm just going to click through this. This is a plan. Test. What's today? So we've got notes. And I think that's everything that's required. This goes through, I have verbal consent to share data from the participant. And then this is the email that gets sent to the referral system so that they know that a referral is coming their way. And this is done, this is linked into the New Jersey 211. So you can see this is the successful referral made right here. Then when you go back into the care management platform, then there is a task generated in this members chart that shows down here. Oh, that's the wrong one. This is the one. To complete the task for the referral requests that was just submitted. So you've got this integration between the two systems where data is passed back and forth. It's passed through the FHIR compliant Smart on FHIR application launch, and it's stored in a FHIR database. So then at this point, when that goal or when that task is accepted here, it's displayed in this system. We have the referrals tab. This piece of it's not set up in this demo environment right now. I apologize for that. But the referral is captured here as well. And then as information is updated on this platform, so when this Social Concern Society of St. Vincent de Paul responds and accepts this, if they want to come in here and they accept this referral, then that update is then reflected back into your case management system. So there's passing of data between the 211 Community Resource Inventory in New Jersey and their case management tool here. Another big thing that we worked on this year was reporting and analytics. That was something else that we looked to build out. In this, I don't have a Tableau license because it's too expensive to maintain a Tableau license. We need to do a demonstration every 3 months. But I did get some screenshots from the Tableau license that one of the developers has. And here, displayed in this piece right here, based on the user and the user's role, is dashboards that resemble this. So this dashboard right here is a dashboard of test members, and it's in the New Jersey Inc. Program in their test environment. This is a administrator's dashboard, so they're able to do oversight among their care managers and then the teams that work within each of the care management teams. So they can see the distribution of the members. They can see how many each person is working with. They can see how many have remained unassigned. And then they've also built out this view to include interactive details down here about milestones that they need their members to hit from a programmatic standpoint. All of these fields, because we're using a third-party app, which is Tableau in this case, all of these views can be customized and built out. So that makes it so that, again, back to that leveraging existing technologies that have already been financed in the organization who wants this technology. We're working with 2 organizations that already have Tableau. They're already using it. So they didn't want to have a new data analytics tool. They just wanted to be able to use this tool within their new platform. Then we have a second. This is another view that shows, again, it's showing the data that's available from the FHIR database about for a particular worker or staff member. This is the people that they're working with. You can come up with whatever it is up here that you need. They chose average care plans. This is to kind of determine like work in progress or workload. And then this is where they can use this data here to guide their daily work. We've done this, we've linked in Tableau, but we've also linked in Data Studios. And currently we're working on a Google Analytics product that we will be able to link in here in the future for that reporting and data analytics, for sharing of the data and reporting your data out. Again, because of the fact that we can like switch it in and out, if you're reporting, if the organization or agency that you're reporting to has a particular analytics tool that they want you to use, then you can leverage that here. It can be integrated into this space. Another thing I wanted to show, this is another Smart on FHIR launch showing interoperability. Within again, I'm back into a member record and I go back into my smart launches. We are able to launch into a physician or a provider viewer This particular viewer is one that we're using in Prince George's County. And this is a demonstration, of course, this is not real data, but in the Prince George's County version of this, it's in their OCP model, which is the generation prior to this. And it launches into their Prince George's County PHIN. So they've got all of their medical data that's linked in. They do tie that PHIN's tied into CRISP in Prince George's County, which is the state designated HIE. And then the health department is also stores their data in that PHIN. And this viewer is linked in directly, smart launch directly from their case management system so that they can go into that robust repository of information that all of the healthcare and other providers within Prince George's County and the state of Maryland are sending their data into. So we've added in, you can pull up, these are just sample data, but like a CCDA type document that might be available on that member, or you can do images, radiology that might be available on that member. And you can see here that I'm specifically in this member. I've gone directly into this member's records that exist within this system. So this is another way that data can be shared between organizations using a provider viewer. And this is the viewer that we're using in Prince George's County, but there are any number of viewers available that could be looked at to be used here. Again, trying to leverage what's existing, or for that matter, you might start with this viewer and 5 years from now, a really great Smart on FHIR viewer comes out and you don't want to switch your whole system. You just want to change to that new viewer. Then it's easy, as Ken had mentioned, it's very easy to switch those out in this modular kind of platform. Sorry, getting over a head cold. Another thing, we've got a couple minutes, so I wanted to show the care planning. I did do one while we were talking, realized that this was going to be a very quick demonstration. We've added in this care planning component. New Jersey is using this currently. These are care pathways. They've divided this out, which based on different pathways that they like to use in New Jersey. And we did this for, so for instance, you would go in and add a new goal. I added this goal just a little bit ago. Sorry. So if you look at the goal, once the goal has been added, all of these tasks that were identified by the clinical team in New Jersey, the steps that would need to be taken to achieve this goal, or the steps that could be taken to achieve this goal, are automatically added into the care plan in draft form. Then they have an interdisciplinary team where they go through and customize, well, do we need to do this? Well, you know what? We already did this during our initial discussion, so we're going to complete that one. Do we need to do a referral for this? Yeah, I think we do need to do a referral. So then they're going to launch their 360 app because this is a social service need. Do we need to prepare them for the upcoming referral? Well, not really. That's not appropriate for a food bank referral. Okay, so then that gets canceled. But the idea is they wanted to encourage equity of care across all members. They wanted to put all the possible things that could be used, or services provided, or support offered into the care plan, and then deduct out what wasn't needed, as opposed to doing it the other way, because the other way is you're dependent on the knowledge of your care manager and what your care manager really is aware of. We have some really strong care managers in New Jersey, no names mentioned, Mary, who is, her wealth of knowledge about what services are available is amazing. And she's got Post-its and notes all over the place. So what we wanted to do was we wanted to take all of her breadth of knowledge and put it in here. So then the care coordinator that just started in New Jersey has the benefit of everything that Mary knows in front of them to deduct or to use as the tool to make the care plan for this member. We had mentioned earlier about the care planning. This is the care plan model that was shared across state lines, or is being shared across state lines in the ACF demonstration in collaboration with CRISP and the MOMS program, which is a opioid use program for mothers in Maryland. And this is the FHIR care plan that's being shared across those state lines. And just as another, so these tasks that are automatically populated are displayed down here in the task section of the care coordinator's workflow. This is where they go to see what work they've got to get done for the day. And the tasks are identified here for them to come in and see what it is that they need to do. The last piece that I was going to go over, do I have a minute? Yeah, I have like one more minute. I just wanted to briefly show the rest of the solution. This is the rest of the solution that's being used in both Connecticut and in New Jersey. This is kind of the first step. This is a provider, or this is a provider portal. They are going to have some of their model includes having outside resources that are going to be doing engagement with the members to get them started into the INC program. And this kind of was that engagement piece happens. So here you've got a list of the members, and then the members each have a very kind of a down and dirty record here. All of the data that's in this system is shared in the same FHIR database that exists in this system. So data is passed back and forth between the two systems. Updates are passed back and forth between the two systems. Sorry. So here in this system, I wanted to kind of show this patient engagement workflow, because this is something new this year. The patient engagement workflow, you would come, so you would open up your member and you say, okay, I need to work with this member. I'm going to start patient engagement workflow. This patient engagement workflow is very specific, and it's been customized to be exactly what they need in Connecticut Inc. So they would go in and they would assign their member. We are currently working to put in a bulk assignment for them so that a care manager could come in and assign all the information for all of their members. During their first phone call with a member, they're tasked with making sure that this particular demographic information is accurate, because it's coming from outside sources. Some of it's from claims, some of it's from physicians that work in the community. So they're to confirm this specific information with the member. They have to confirm guarantor information. This is a program for children. So the guarantor information is confirmed. They'll also make sure that the person is interested in participating in the completing an assessment, an initial assessment, and then sharing that data with their physician. And then usually that session is scheduled for some time in the future. They haven't defined what these are going to be yet, whether it's going to be an in-person session, etc. Then they can come back here and document their interaction. This COMEX is another third-party technology that's been integrated into here. It allows for voice over the internet for both SIM and for email, so that if the agent or the organization who's using this technology wants to have that recorded, they can. That's something they can purchase outside. So then the outcome of the contact is noted. Test, save. And then this allows for you to go through, I was just trying to go through a quick demonstration. You can have multiple contacts here. Then this is getting that assessment completed. This is that next step, is getting the assessment completed. The assessment as it's designed is a member facing or a patient facing application. I wanted to show you one that's what it looks like when one is completed. So here we have a completed assessment. And then from that completed assessment, you have a scoring rubric that's been put in on the back end to do the scoring for you. And then the report with all the results is generated from these are all questions on that assessment. It's extremely thorough assessment. These are responses to all of these social determinant of health questions, and as well as medical health questions and behavioral health questions, et cetera. It's really a 360 assessment that's patient facing. But the system allows for a report to be generated from all of those questions. And then this report is then interoperably shared with the provider, the primary care provider or the pediatrician for that member, so that they can, and the provider gets paid a stipend for reading this report. So I went through this really quickly. And again, if you wanted to do a more, if anybody wanted a more detailed demonstration, we certainly can set that up, but we're at 2 minutes before the end of the call, so I want to be respectful.
Michelle, let me ask one quick question, which is you showed the human being double checking to make sure that that address was correct. But what do you do in the system when you've got multiple data feeds already on that child or over time on that child, and they come in telling you that there's different addresses, which, as we know, there's a lot of housing instability. So what would happen in the system with that disparate information in order to flag a human being to work with the family to figure out which one's right?
You know, I don't know the exact answer to that, so I'm not gonna wing it. I do know that there's patient matching on the back end to ensure that we don't end up with duplicate records. And the patient matching has a standardized scoring for the value of the address. And since people are transient, the value of the address is kind of marked as a low score, so that it's not going to create a duplicate record if you've got the same name, the same other identifiers, and the address is different. So the matching is done on the back end to ensure you don't have duplicate records. But I'm not exactly sure about how the reconciliation is done with the multiple addresses when in that case. We haven't run across that. We're still working on figuring that piece out. So I'm not exactly sure how to answer that.
Okay. And, I think the same thing could be true of clinical or social information as well, too. Coming from different sources, you get, different versions of diagnoses. You might have one source telling you that the family's homeless and the other that they're, housing, insecure by some other definition. So, these are very complicated things to reconcile and to figure out. But I think you have a roadmap, right, towards trying to work towards these issues.
Yeah, I think, well, as far as the outstanding data, like when you get past the patient matching, as far as the extended data, that's all captured as separate attachments. So the results of this social service assessment that's done is captured as an attachment. So it's a moment in time assessment, and it's stored under attachments within the patient record or within the member record. Then as far as the reconciliation of all of that information, you're right, that is something that's on the horizon of things that we're working on getting it up to the pole, but they've got a temporary.
Right. So as we improve this interoperability of data from other domains like child welfare, education, et cetera, those are issues that still have to be solved then.
Yes.
Great, thank you very much.
I know we're at a little beyond time here. There's one last question Bill has about utilization, I guess, is your point. Are people using it?
This is stood up in both New Jersey and Connecticut. Right now, this specific model is set up for Inc. in both New Jersey and Connecticut currently. We have, as Ken mentioned, we have the diabetes prevention program. Prevention Link in Prince George's County is using a earlier version of this system in Prince George's County. And we have several things in the pipeline for this coming year where we're hoping to be able to stand it up in 2 other instances this coming year.
Cool. So lots to learn and lots to see what happens this year.
And then, yeah, I was
Horizon.
gonna say, for Jan's question, that'll be answered in February by May, June, because they're the ones who create the assessment in that report.
Right, right. Dave is, I don't think we have a firm date. I think we're talking next couple of days, so we'll have some more definition about that presentation as well. So I think we're ready to wrap. Again, thanks Ken and Michelle for presenting, and everyone else. A good way to kick off the year. Lots of really interesting stuff coming our way, which will be great. And we'll post, as we always do, we'll post the materials on the NIC Hub and then go from there. So we'll see everyone in a couple of weeks, and you can reach people there as well. So if there's questions or other commentary, look forward to hearing it, and see you guys again in a couple of weeks. Okay, have a great night.
Thanks, everybody.
Thanks, Ken.